I know that there's a lot of you in this audience that I do know. There's some of you that I don't know. So I'll give you a little bit of additional background to what Ron said about where my passion comes for changing healthcare, because that's really why I left Houston and the world's largest medical center to come here, is because of the opportunity that I see that's right here in Idaho. So let me tell you a little bit about where my passion comes from. It really gets back to about age 6, when my brother, who was also my best friend, had to go in the hospital, and he was in and out of the hospital for about 9 months. And it was very scary for me because, first of all, I didn't understand what was going on, and just understanding that he was sick and he had to be in the hospital. But at that point, I really developed the desire to become a physician. I thought, I'll become a doctor and I can keep my family healthy and everything will be okay. Well, I discovered as I grew up and continued with my desire to become a physician that I had some obstacles to get over. And one of those obstacles was every time I went into a hospital, I passed out. And so that was the view of me. In fact, in high school, we had career day, and 24 girls and myself went to the hospital. They took us to a neonatal intensive care unit. You'll appreciate this, Dr. Janice. And we're walking through there, and you have these babies in the little bassinets and everything. And I went down, hit one of the bassinets on my way on the floor, and the worst part of it was none of the girls passed out. So I couldn't even go back to school the next day. It was so bad. So obviously passing out every time you go in the hospital is kind of a challenge if you want to be a physician. And my parents started telling me, gosh, David, why don't you think about business or law or something like that? So there's a warning right there to all of you parents. Be careful what you tell your children because they may do everything. But I said, I really want to become a physician, so I stuck with it. So when I was in college, I went to the hospital and I said, I think the best way for me to get over this is immersion. So I want you to, I'll volunteer, you don't have to pay me, just put me in the grossest place that you have. And so, Ray, you'll remember Herman Hospital, they put me in the surgical intensive care unit, and it gets all the trauma and life flight patients and burn victims and so forth, so it is pretty intense. But great things came out of really trying to overcome those challenges. First is after I got done with that, there was only one more time that I would pass out, and that was on urology in medical school. But besides that, I got over my fainting. And the other thing is, I actually met my wife there, who was a nurse in that unit. So a lot of good things in overcoming those challenges. But I think that as we talk about some of the challenges now that face us, those of us in healthcare and those of you paying for it, is that we may find some examples of times when you're going to want to pass out like this too, but we'll try to talk about some solutions. So what is the crisis? And I think that a great way to demonstrate it is looking at the shark's jaws. Really, you can sum it up by looking at the two jaws as axis. On the lower jaw, that's really what's been happening to corporate earnings, personal earnings, and the upper jaw is the rate of growth of healthcare expenses. And we understand it is going up too fast and too much, and that we've got to do something about it. In fact, one of the things is that people forget a lot of times that healthcare is also a business. And so when we looked at ourselves, what the impact of the healthcare reform bill was to us, what if we were to stop offering employer-sponsored insurance, and we drove all of our employees to the health exchanges that are going to come into effect in 2014, one way or another, unless that law is overturned. that even if we paid the penalties for doing that under the healthcare reform law, we would save $42 million every year. Amazing. I mean, that's the kind of magnitude of this problem for employers. And that's not all. Frankly, I'm not as much scared of this as I am this. And that is that we have an aging country. In fact, by 2050, it's expected that we'll have a 149% increase in those that are 65 and older in this country. Compared to the rest of the population, it's only going to be increasing at 49%. So we are going to have more of the elderly, and of course more healthcare costs with that. But also, even worse, is what's happening with our young folks, and that is the epidemic of obesity. We at St. Luke's, our employee base mirrors the national problem, and that is that a third of our employees are normal weight, a third of them are overweight, and a third of them are obese. And this is the problem that is happening with our kids as well, although it's accelerating. And we've got to be very, very afraid of this, because despite all of our efforts today to address healthcare costs of patients, and that's what the current healthcare system focuses on, we've got this pipeline of disease burden coming our way, because as these kids get older in 10, 15, 20 years, they're going to have dramatically increasing rates of high blood pressure, high cholesterol, diabetes, heart disease, arthritis, and even now we have a lot of studies showing a direct connection between obesity and the development of certain types of cancers. So let me tell you, with the challenges we have today, the system is not going to be able to sustain what's coming our way. We're going to have to figure out how to address this. So at St. Luke's, we're looking at ways of how can we stem this, what can we do, and to try to promote health and decrease the cost burden that's coming our way. One of the things that we've been looking at is some new data that's coming out about patient activation. So, you know, it's very hard to change lifestyles, and the American diet is deteriorating. The technology proliferation that makes our kids and our adults less and less active. We've got all these things working against us being in good physical health. Plus, it's just hard to change your lifestyle. So how do we get people that need to adopt a better lifestyle to do it? We've been looking at a number of things. What are some incentives we can offer? Of course, one of the big objections to the healthcare reform bill was, okay, it talks about accountability for payers and accountability for providers, but where's the accountability for patients? What are they going to do in their role to decrease healthcare costs? And of course, there's not much. But we've been looking at some of this data about patient activation, which is how do you get the patients to change. So today, what happens is if you see me as the physician, I'm going to tell you what to do because I have that specialized knowledge, you don't. I'm the doctor, do what I say, and everything will be good. So you're the recipient of health. Well, we got to change that. We got to change it so that patients get engaged and they own their health, and that they're responsible for it. And in fact, we have to take it another step forward to where they're activated. So what causes you to actually make a change in what you're doing? It's one thing to know. I knew, as a physician, I knew what I needed to do about my diet and exercise. It was not a mystery to me. The question was, how was I going to do that with my travel schedule, with all the meetings, everything that I go to where people feed me, all these kinds of things, and I'm just too busy, and all the excuses I can make up. So what we did is we started using some of these data to see if we could change people, and I decided if I was going to be the leader, I really needed to do what leaders are supposed to do, and I needed to start with myself. So last year, I started a program, and now I have lost 63.5 pounds in 1 year, and I'm exercising an hour a day. And if you had told me that a year ago, I would have never believed that that could happen. because I have tried many, many times and it's never been sustainable. So we're encouraged that we do have some ideas. It's going to take more than that though. And we have done a lot of efforts. Most of those efforts still haven't bent the cost curve. The costs continue to go up. So why isn't this working? Well, the reason to us is that the system has failed. We are propping up a broken system. And that system, that foundation, is fee-for-service. It's payment for everything that we do. And it's paying providers, physicians, hospitals. Every time you do something, you get paid for that. And worse, typically we're mostly in control of what those services are. So this is a fundamental problem that we've been attacking in a lot of ways, but it's not working. We keep on gaming it. We need a new system. So we've tried, a lot of employers have tried things to do plans. Our newest program at St. Luke's we've implemented, the Healthy You program. We are seeing some success from this. My own journey has inspired a few of our other executives, and so we've seen some results there. In this program, we had 10 people in our IT department that lost a half a ton. It's amazing, amazing. But we are applying some of this new information about how to help people change and be successful with this. I also talked to one of our security guards, and he came up to me and was just thanking me profusely while I was actually waiting in the emergency room for one of my family members to be seen, and said, "This is so great. I've been smoking for 25 years. I've never been able to stop, and this program helped me, and now I'm completely off tobacco." But it's still not enough. It's still not enough to do what we need to do. So if you look at our current model, this fee-for-service model, it's really like the 12-headed hydra. And if you look at the healthcare costs. And certainly payers have tried to do a lot of things, even lopping off heads by saying, you know, what we're going to do is to control these costs, we're just going to decrease the reimbursement. But what happens is the providers the beast just gets angrier, it grows another head, it gets bigger and bigger, because as we decrease the reimbursement per unit of service, it just results in doing more units of service. So it's getting away from us. CMS, which is the Centers for Medicare and Medicaid Services, oversees the Medicare program, they too in the past have done a lot of these things, and they've done some things that unfortunately have put the incentives in direct conflict. They have paid hospitals in one way and paid physicians in a different way that don't align to achieve the same kind of objectives. And so it's really not surprising that this hasn't worked. We're going to have to do something else. And what CMS does is very important, because it does tend to be where insurance companies across the country follow. So we're going to have to do something different. You know, for those of you old enough to remember the Cold War days, and you remember all those drills where we would have to get under our desks and we just do the duck and cover. And I remember for myself, first of all, I never really believed that the Russians were going to bomb us, and I don't think my parents did, because we knew what that meant. And second of all, even if they did, this wasn't going to work. Okay, so I don't know what we were thinking, that gosh, if I can just get under my desk, I'll be okay. And unfortunately, this is what's happening around the country with a lot of physicians in hospitals, and I'm still amazed at some of the meetings I go to. Fortunately, it's the minority, but a few people still hoping that they can just duck and cover, and this is going to go away, or they can ride it out. Well, I have to tell you, I think that duck and cover is not going to work. We are going to have to change. This isn't going away. We've got to deal with it. But the problem that the providers are facing is, you know, we're in one world today. And most everybody acknowledges we need to go to a new world. But the problem is, how do you make that leap? And especially if everything's working for you today, what's the incentive to make a leap to something that may not work as well for you in the future? And it's a little bit frightening when you think about you've adjusted your business model one way and it's working, but you realize you not need to change the business model, but will it work? And so one of the fears is that you get out ahead of it. And this has been something that has been holding a lot of us providers back, is you don't want to foolishly get ahead of it and hurt yourself. I had an example in Houston. There was a neurosurgeon that I referred all of my tough back and neck cases to when I couldn't manage them myself. And the reason I referred him to him is he was an outstanding surgeon that got very predictable outcomes. And of the people that I sent to him, he probably only operated on 10%. He was very conservative, and he knew, I don't want to operate on somebody that doesn't need it, because otherwise they're not really going to be better off. But the problem is, one day he came to my office and he said, David, I'm retiring. And I was shocked. And I said, I don't understand what's going on. And he said, the problem is that I'm spending most of my time in the office instead of in the operating room. So I'm getting office fees instead of surgical fees. But I have the same overhead that all the other neurosurgeons have, and I can't make it anymore. And so rather than do unnecessary operations or gin up the procedures, he said, I'm getting out. So here's an example where, moving too fast, the system works against those people and will make them unsuccessful. And so how are we going to do this? So what does this new world look like, and what do we need to achieve? For employers, we understand at St. Luke's, being an employer ourselves, what we need to do is we need to give you some predictability. We need to normalize these costs. And we understand that these costs can't keep growing at a rate faster than your businesses can support and that the economies can support. And what we think is that if you start in Idaho, Idaho already is a pretty low-cost state relative to the other states. It's too high a cost, but it's low relative to the other states. We think we can actually do a lot here. We think that we can actually make this even much lower cost, and we realize that in doing so, we're going to provide businesses of Idaho a competitive advantage, and that's good for us. Because first of all, we can retain the businesses we have, and hopefully we can attract other businesses because we can manage those costs better in a new world. The other thing is that we think that the models that we're talking about, where we're not just focusing on how to return sick people or ill people back to health, but how can we maintain the health of people that are currently not patients, is going to lead to healthier, happier, and more productive individuals. And why this is so important is that when people are not in this state, it costs you money. The recent study in 2009 showed that for every dollar that you're spending on health care, it's impacting your company $2.30 in productivity. So we understand that what we got to do is try to take care of people and keep them healthy. And we think we have some ways to maybe do that. So what's it look like for consumers? This is something that drives me nuts. I give the example of, there's things in healthcare that I would never tolerate in any other business. I give the example of a single mother who has a bladder infection, and she has kids to get off to school the next day, but she develops her symptoms at evening after the doctor's offices are closed. She has to wait till the next morning, till 8, 9, whenever the doctor's office opens, to call to see if she can get an appointment to come in and take off work, to come in and see the doctor, to get the prescription she needs, and she can't do that till the next day. And so she has no predictability in terms of, can I be there when my kids are getting home from school, or do I have to make other arrangements, that kind of thing. That same mother, if she found out she had a family emergency out of state at night, could get online and schedule a flight and make all of her arrangements and know when she's heading out of town and what arrangements she needs to make, but she can't do that in healthcare. And so what we've got to do is we have got to make this more consumer-friendly, more patient-centered, and we are working on that actively today. We are spending $100 million to put in an advanced information system in all of our physician offices and all of our hospitals. It's going to take us several years to do this, but we've already started implementing. And we are making it so that now you could schedule an appointment online. Now you could email your physician. Now you could even see your medical records online. And so these are going to be great advances. And where we've got to get as we change this model, just as an example in the one I gave you about this bladder infection, here's an example of why the fee-for-service system needs to change. A bladder infection for a physician is a pretty simple thing to diagnose and to treat. But what happens is in the fee-for-service world, I don't get paid unless I see you. Okay? I don't get paid for treating you over the phone. And I've still got my office overhead and everything else to take care of. So what's going to happen is we're going to make that single mom come into the office because that's how we get paid. But what if we were in a different system that didn't pay you for every single thing you did? Because frankly, what I could probably do is handle that over the phone. Might even be able to just handle it over some email exchange. We save that mother from having to take off work, and she may be your employee that's having to take off work to do this. So she doesn't have to go in there, and her whole day's not disrupted, and she got the same quality of care she would have gotten otherwise. That's just a small example of what we need to do. But the other thing we've got to do is we have got to make sure that we're not hurting patients. You can't read this. I'd be impressed if you can. This is a 12th century Byzantine writing that is the Hippocratic Oath. And I and a couple other people in this room took that oath when we became physicians, and part of it was that we wouldn't do any harm to people. And unfortunately, despite that, healthcare is doing harm. Healthcare is the fourth leading cause of death in the United States, and that's unacceptable. Too many people are getting hurt. Now, there are some things that we do that are very, very high risk, and when you weigh those risks and potential benefits, you'd still decide to do it, and so some people are going to have a bad outcome. I'm not saying that it can be completely eliminated, but it can be a whole lot better, and we're demonstrating this. We are already doing work across the entire system that can decrease the incidence of patient harm, and we're already seeing the results of it. And there are some ways to do this so that we can minimize that. But more than that, when I was first asked to look at this position here at St. Luke's, and I was in Houston, the first thing I did after the recruiter called me and asked me if I would look at it was to get online and start researching the health system. And what I did is I looked, the very first thing I did is look to see if the flagship hospital was a magnet hospital, because I wasn't coming if it wasn't, and it is. And magnet is a tremendous accomplishment. It's a designation for hospitals based on our nursing practice. And this is so important because it's those nurses that are there 24/7. The doctors are in and out, but the nurses are there all the time. We rely on the nurses to recognize problems before they become problems, to carry out the treatments, and to make sure that those patients still stay safe. And unfortunately, there's only 2 hospitals in Idaho that are magnet hospitals. Our Boise and Meridian medical centers for St. Luke's, and the medical center in Kootenai is a magnet hospital. And they're called magnet because this culture of nursing excellence and advancing nursing education, research, clinical practice, collaboration, all that kind of stuff, is a magnet to attract other nurses. And so that's the first thing. But the second thing is, I looked at the quality information to see how were the hospitals doing. And here's what I learned. I learned that we had one hospital that was the best in the state for a particular condition. And I looked and saw that we had another hospital in the system that was worst in the state for that same condition. And then I looked at that hospital that was the best in that one condition, but saw that in another condition, it didn't perform as well as another hospital in the health system. So this was very disturbing to me. What it showed me, and frankly, I wasn't surprised because this is typical across the American health system, that you have variation between hospitals and variation even within hospitals. And so for the past 2.5 years since I've gotten here, and Tom Saldine's on our board, he can tell you I have been relentless about how do we become and act like a system instead of a confederation of independent hospitals. How do we take our quality improvement efforts and disperse them across the whole system and float all boats? How do we identify best practices wherever they occur? And they don't all occur in Boise. How do we identify those best practices and then make sure that's adopted across the health system? And I'll tell you what, after all this, it's working. In fact, just last week we were notified by Thomson Reuters that St. Luke's is a top 50 health system based on quality metrics in the country. Out of 321 health systems, St. Luke's is in the top 50. We don't know where in the top 50, but they just said we're in the top 50 for quality. And what I'm proud about is because that's a look at the whole health system. Now, we're not where we need to be, and I'm not going to rest as long as there's any opportunity left, but it's to show you what we can do if we change the way we're doing things and look at it and incorporate, frankly, some best practices that come from other industries and not been in healthcare. So then I think this is an incredibly important point. We've always learned that an ounce of prevention is worth a pound of cure. And let me tell you, that's true. If I can save somebody from becoming a diabetic, I can save lots of healthcare costs. If you tell me here they are, they're already a diabetic and now I need to manage them, yes, I can try to manage those costs down, but it's going to be much more costly. We've got to figure out a way to do prevention, and we've got to find a way to incentivize and pay for it. You probably aren't surprised, but maybe you will be, that as a general rule, healthcare providers are not incentivized and rewarded for providing prevention. We're rewarded for applying very high-cost technical medical services to people that are already ill. And this is why none of the healthcare organizations in the country do as much as we need to try to improve the health of people who aren't already patients. If you ask me what do, we take care of patients. And we need to get in a new business. We need to take care of people before they come patients and keep them from becoming patients because our system can't sustain it. And we know that. So what's the answer? There we go. What's the solution? We think the solution is accountable care. Now this has already become a buzzword across the country, but let me talk just a little bit about it. We think what the accountable care is a real full implementation of the triple aim. Better health, which I told you right now, we're not in the health business. We're in the health care business. We don't get paid for health. We get paid for giving health care to patients. But we've got to have a new system that provides better health. And we've got to do better care. I told you that even though we've made a lot of accomplishments, my job's not done, and all of our jobs is not done. We've got a lot more that we can do, and I'm not going to settle until we are at the very, very top doing everything the very best they can possibly be. And with better health and better care, we've got to deliver it at a lower cost. And we think there's a lot of cost that can come out of this system if we can get everybody aligned and we can create the incentives that will align. Because right now, healthcare is just a complete mess of mixed incentives that don't align and create people, we're paying people to do things that's not really what we want them to do. So we got to change that. And if we can accomplish all of this, better care, better health, and lower cost, that's where value will come. And we think that's the answer. Pay for value, don't pay for volume of services. So how do we make this a reality? Let me just give you one example. And then I'm going to try to save plenty of time for the Q&A period. We can go into a lot of other things. But we're not utilizing technology in healthcare to the extent that we can, and to the extent that it can help us improve care and improve health at lower cost. You know, one example is that diabetic patient I was telling you about. If they came into my office and I saw them, I would do their examination and everything. I would sit down with them and tell them, okay, you've got diabetes. Let me tell you about, here's what diabetes is, here's what you need to do. And I do that every time. Well, first of all, that's kind of crazy. Why do you use the most expensive providers, the physicians' time to do this education? That's not the best use of resources. So going back to the woman with the bladder infection, the other thing that you would do is you wouldn't have a physician take care of that. You'd have a lower cost person. I mean, that is, as we said, is a much easier thing. In fact, why do you have to wait to see whether you can get on my schedule? Why can't you see my physician's assistant or nurse practitioner? Or better yet, as I mentioned, why can't we just take care of this over the phone and save you cost? But for the diabetes, so I'm going to go through this with every patient every time. Well, we don't need to do that. Plus, the other thing is, the problem is, after I've had that discussion with Ron and taken up all my valuable time, he's going to go home. And now his wife's going to say, well, what did Dr. Pate say? And he's going to say, well, he said I got diabetes. And she's going to have like 100 questions, and Ron's going to be like a deer in the headlights, and he's not going to know the answers to this, and she's going to say, you idiot, you've been gone half a day, and this is all you know? I mean, what did the doctor say? So we got to do it in a different way, and what we can do is we can take, for example, we're already doing some of this. We're not all the way there yet, but taking video high definition content where we have a physician give this information, record it, not me doing it every single time, and then we can push it out to the patient. It can be at the patient's home before the patient ever gets home, and Ron can say, wait, slow down, let's just bring this up, and he and his wife can sit down and look at it together. And then his kids, because mom now has called all the kids and said dad's got diabetes, now they're all freaked out. So what Ron can do is shoot this as an email content over to all of his kids that are out of state, and they can learn about what it means that dad's got diabetes. So we can do that for patient education. We can do other things. We can, during the period of time that I was working on my weight loss, one of the things for me is I need incentives. I need to be able to see that I'm making progress. That keeps me encouraged to keep. So what I did is during the period of time, I had apps on my iPhone. I was recording my progress, my weight, my BMI, my measurements, those kind of things. And even at times when I was getting a little discouraged, then I could look back at my app and I could see, well, gosh, actually I made a lot of progress. And one time I thought I wasn't making much progress. Once I looked back on the graphs, I thought, wow, I actually did a lot more than I thought I did. So there's things that we can do in terms of that. But frankly, we could get to the point where a lot of these things we're managing from home. Why can't, when I step on the scale at home, why can't that information be uploaded to the electronic medical record my physician has? In fact, for Ron's diabetes, why can't I give him a glucometer that he has at home, and when he's checking his blood sugars, that information's uploaded to the electronic medical record? Another part that's broken about fee-for-service is it encourages us to take care of illness in episodes. In other words, again, you remember, I'm only going to get paid for taking care of Ron in today's environment whenever he comes into office, or if, God forbid, he has to go in the hospital. But the problem is, when I see him and I tell him he's got diabetes today, and I set up his return appointment for 3 months, Ron still has diabetes for that 3 months. And we're losing an opportunity. I won't be doing anything unless Ron calls me. But in fact, in the new world, if we were paying for value instead of fee for service, I could be managing his diabetes from home and this whole time and not wait for it to get worse, and particularly not wait. They always seem to get worse on Friday afternoon just as the doctor's office is closing, and guess what? They now end up in our emergency room. When instead, if we could have had an electronic medical record, a little range, said this is where we want Ron's blood sugars, it's uploaded there. Now my PA or my nurse practitioner sees, whoa, wait, Ron's starting to get out of whack. He doesn't even realize it yet, and he's not feeling sick, but we could see it in the physician's office and say, we got to adjust Ron's medication. Or we got to figure out what's happened to him. Has he stopped exercising? Is he not, has he changed his diet? What's going on? So we can make an intervention. So those are some things that we need to do. Also, Idaho is a very rural state. We have a physician shortage. We could be offering some of the high-tech services if we could establish telemedicine across this area from physicians in a virtual visit that don't have to go physically. So we don't have to have, again, patients uproot them and have them travel all day to come in to Boise or some other place. And we don't have to have the physician traveling, and we can accomplish this in a lot easier. Now, the problem is, of course, that for a lot of payers, they don't reimburse for this. So again, how's this going to happen until we change our incentives and our alignment for what we're doing? So I know that, how does this come together? Well, if you look at what CMS is doing, they're creating a blueprint for us. And a lot of people on my team look at this blueprint and they're about ready to pass out. But they actually, CMS, for the first time in a long time, has actually come up with what we think is a pretty good idea in something they call the Medicare Shared Savings Program. And in fact, St. Luke's is preparing to get ready so that we could participate in that, which would be a little bit of a different, it's a step in where the payment needs to reform, so that if we can save the federal government money, we could share in those monies. Because see, my fundamental problem is that I need physicians to start eliminating unnecessary services and low-value services. The problem is that those are the same services by which they get paid. And so I need them to do less, but it's also going to hurt the hospitals. Because if Dr. Priest does everything that hopefully we could incentivize him to do to manage patients that will keep them well, it's also going to keep them out of the hospitals. And then we're going to, and so we don't want to be like that neurosurgeon I talked about in Houston, where we get out ahead and go under. But this is a step in the right direction where we can save some of those savings, so that when Dr. Priest does some fewer procedures, I can at least pay him. Hopefully there'll be savings and I can give him payment in a different way. So that's what we need to do. But the scary thing is after we build this airplane, and it's never flown before, who's going to be the first to get on it? And for us, as I've been saying, we need to kind of all get on board. And the problem is, who's going to make the first step? Who's going to be the first one to go in that plane? But we've got to commit. And I think the reason, if we talk about it, and if we really think about it, I think the way that we can get everybody to get onto the plane is if we think about what's the cost of inaction. It's got to be more painful not to change than it is to change. And change is painful. It's very tough. But why should we want to go ahead and change? Why should we want to all get together and all of us make the changes? Because it's going to take changes from the payers, it's going to take changes from the employers, it's going to take changes from physicians, changes from hospitals. How are we going to get everybody to change at once? Well, there's some very serious costs of inaction. And one of those costs is, and it always tends to happen to Wile E. Coyote, he pays the price in the end. The system is going to break. It is going to break. And we got the pig and the python that I already told you about. All of this disease burden is coming our way with obesity and aging. And so that's going to overwhelm the system. But we have a more pressing problem. Unless the healthcare reform bill is overturned by the Supreme Court this summer, then Dick Armstrong is going to add to his rolls of Medicaid patients by 50%. We're going to have a 50% increase. We don't have enough physicians in Idaho to give that, to meet those needs. And if you suddenly have all these people that now have some kind of coverage and you throw them into a broken system, guess what? It doesn't get better. And this is what the fundamental reason why St. Luke's we believe there needs to be healthcare reform. We just thought that the federal law was the wrong way to go about it because it takes what now is just shy of 50 million people that will become insured one way or another in 2014 and puts them into this broken system. And it's not going to get better. And in fact, it's going to compromise access more. So, because we don't have enough physicians. So it's going to require us, we have to change that care model. We can't have it that I have to see every bladder infection. We can't do that and meet the needs of people, or guess where they end up? They end up in the emergency rooms. And that is not going to lower healthcare costs. So, we've got to commit. It is unnerving. You're going to feel like fainting. But the other reason we got to do it is finally, as all Americans, we've got to realize we've got to do our part to address this problem. I certainly have little confidence that Congress is going to do this, so we better figure out how to do this. But we can't just keep driving up the federal deficit and the federal debt. We've got to find ways to stem this healthcare costs. So, as you think about what do we need to do, as I said, we've got to all come together. And we've got to work together. We've got to all get on the same boat, and we've all got to row in the right direction, the same direction. And we can do this. And we have a community where we could actually work together. And so that's one of the things that I saw about why I was so excited to come to Boise, Idaho from the Texas Medical Center. Because let me tell you, in the Texas Medical Center, as great as it is, there is no way, they're all going to fight over whose boat. And let me tell you, and then they're going to fight over who's going to be this guy telling them when to row. And they're going to be fighting about that for years. And so that's the opportunity that I saw in Idaho. That we could come here, we actually could all get together and we could row in the right direction. It is going to be a lot of work. And we've got to decide if we all really agree with the need to change and how it's going to have to change. And then if we do, we're going to have to work together to educate our employees. And in fact, I was talking to Director Deal, and last night I was talking to one of the legislators. All of you saw yesterday that the governor has now kind of given up on pushing for the state insurance exchange. He's been beaten down. I was talking to one of the legislators about the craziness that's going on in our legislature. And this is one of those things that there's actually, outside of the legislature, there's bipartisan support. It's one of the few things that actually, if you survey Idaho citizens, which has been done, by and large, Republicans, Democrats, and Independents all agree we ought to have a state exchange. The people say we ought to have a state exchange, and yet it's probably not going to happen now. We got to either hope that the law gets overturned by the Supreme Court, and that is a risky bet, or we're going to have a federal exchange. That's what's going to happen. Our only hope at this point is to get enough people to understand this complicated issue, but we can narrow it down. It's really pretty simple in the end, and that is, unless this law is overturned, Do you want the feds to run our exchange, or do you want the state to run the exchange? And let me tell you, I want Director Deal running it. I do not want the feds doing it. And so does business, and so do the insurance companies, so do healthcare providers, and even the people are saying this. So we're actually all aligned, and until we make the legislators understand that if you don't support it, then we're not going to vote for you, it's probably going to not happen. So we've got to figure out how to get this word out, how to mobilize people, make them informed consumers, and help them stop some of the craziness that's going on. But to do what we want to do, we need partners. And as I said at the very beginning, a lot of you have already been through innovating your businesses. I know that Bill can't have an inconsistent quality product and his business survive like healthcare does. He's got to be able to consistently deliver a high quality product, and he does it. He's figured out how to do it. We have to do it. He's also found out how to compete in an international market. We've got to do that. We've got to be competitive. But we need partners and we need collaborators, and we're willing to drive innovation in it. Because frankly, even with all that I've talked about, I think that it's a very good start, but we're still not going to get to be where we need to be. We've got to completely innovate the care model and the business model to get where we need to be, but to show how serious St. Luke's is about it. And as I told you, it is scary for us because it means leaving what we're comfortable with and going to a new model that we may not do as well under. So that's scary. But to show you how committed we are is that we actually created a Center for Healthcare Innovation. We're one of the few health systems in the country that has that. And we went out and did a national search, and we recruited the person that we could find that wasn't embedded in the traditional healthcare system. So it's not somebody, oh, I'm going to do this because we've always done it. We wanted somebody to look at it from the outside with enough knowledge about healthcare, but not too much expertise on how you actually run it. Because we want them to challenge us, push back, give us new ideas, help us develop the discipline of innovation. And we found that person in Tony Tomasic. So I'd like to introduce our Chief Transformation Officer, Tony Tomasic. And Tony, you want to say a couple words?
Thank you. Thanks for the introduction. I want to echo Dr. Pate's sentiment and say how much I appreciate the opportunity to share some time with you guys today. Clearly, taking a look at the invitation list and the participants, you guys are innovative thought leaders. You have forwarded your businesses based on opportunity, and you're willing to take the risks that are necessary to ensure your future success. I came from the Innovation Center at Humana. It's an 11-year-old innovation center within one of the most conservative industries in the United States. And I operated in a disruptive fashion in the context of a very conservative group of executives, and somehow we found a way to thrive. One of the things that we did while we were operating in the Innovation Center was find opportunities to partner with unlikely external industry experts. Finding the people who had a like mind around potential outcomes on the behalf of consumers and drive solutions that wound up being mutually beneficial. These were revolutionary, they were challenging, and they were hugely exciting. And that's the sort of thing that we want to try to bring into St. Luke's and into the Idaho region as well. One of the things that I wanted to make sure I expressed to you today was that it would be easy to distill out this action plan as being some sort of a sales pitch around Healthy You to the major employers in the region. And while that would be helpful, I don't think that that's really adequate to solve the problem that we're talking about today. I'm asking for business leaders to connect with St. Luke's, partner with us, and co-author the kinds of solutions that are actually going to be successful for our mutual benefit. And I look forward to working with all of you. Thank you.
Thanks, Tony. So, as part of this, the other thing is, at a time of change, and I've got a pretty large ship to turn, one of the things that's critical is communication. And people have to, if you want to have them change, people have to understand why they should change and what are we changing to and what's going to be the benefit. So as I found a challenge with how do I communicate with 10,000 people who are spread out over southwestern Idaho and eastern Oregon, how do I get the word out to them? How do I, even when I go around and go touring through the health system and meet with employees, I only meet with a fraction of all the employees because people work different shifts, different days. Some people can't get away from the patient care. So I started a blog trying to help see if I could communicate better to physicians and employees what we're doing, why we're doing it. Here's some perspective of the journey that we're on. And we talked a lot about do we want to, keep all this secret and everything. We decided no, we want to be transparent. We need to be transparent. We need to be a lot more transparent, and we're going to start setting the example by making this open to anyone. So you have cards at your table that have the address to my blog. I know some of you have already been on it. And for things that you want a lot more detail, I mean, we only started it a couple months ago, so I'm still writing the content, but I write every single word of it. I don't have somebody else do it for me. And I do, thank goodness, have an editor who helps clean up my writing, so Roya is great, but it's all my writing, it's all my words, it's all my thoughts, and they're out there, whether they're right or wrong, they're out there, but we're trying to set the example of transparency in the way we need to go. I'd be very pleased for you to follow that, and so far a great response from our employees, and I think a growing number of physicians who are starting to read it and understand. And plus, I think if you say you want to be innovative, you ought to be at least using some contemporary kinds of modes of communication. What I'm extremely pleased about is I was able to go home and tell my adult kids that I am tweeting, and neither one of my kids were tweeting, so I taught them.